Hi everyone, I'm Ashley Bassett.
And I'm Catherine Logan.
And welcome to the Sports Talks podcast. On each episode, we chat about the most recent developments in sports medicine and dissect through all the noise so you know which literature should actually impact your practice. Today, we're coming to you live from the American Orthopaedic Society for Sports Medicine annual meeting in Washington, D.C.
The AOSSM annual meeting is the premier sports medicine conference each year, hosting over 3,500 attendees with hundreds of posters and paper presentations, exhibitors, and instructional course lecturers. This year proved to be as spectacular as years past. We were fortunate to have the opportunity to catch up with many of the presenters at the meeting and get their take on some of the hottest topics in sports medicine.
Over these 7 episodes, we're going to be exploring some of the hottest topics in sports medicine with these experts who are presenting at the AOSSM annual meeting.
We are supported by MEOC Orthopaedics. MEOC Orthopaedics is leading a shift in the treatment of anterior cruciate ligament tears from reconstruction to restoration with the Bair implant. Bridge-enhanced ACL restoration facilitates healing of the torn ACL. Unlike reconstruction, the Bair implant does not require a second surgical wound site to remove a healthy tendon from another part of the leg or the use of a donor tendon.
The Bair implant acts as a bridge between the two ends of the torn ACL. The surgeon injects a small amount of the patient's own blood into the implant and then inserts it between the torn ends of the ACL in a minimally invasive procedure. The combination of the Bair implant and the patient's blood enables the body to heal the torn ends of the ACL back together while maintaining the ACL's original attachments to the femur and the tibia. The Bair implant is resorbed by the body as the ACL heals. To learn more about the Bair implant, including clinical study results and instructions for use, visit www.bairimplant.com.
I have an awesome guest today. Dr. Scott Rodeo is a professor of orthopedic surgery at the Weill Cornell Medical School and an attending surgeon at Hospital for Special Surgery. He is the head team physician for the New York Giants, co-chief emeritus of the Sports Medicine and Shoulder Service, as well as vice chair of orthopedic research.
In addition to that, Dr. Rodeo is also the director of the Center of Regenerative Medicine and is a renowned expert in the field of orthobiologics. So we're really excited to hear more from him about this rapidly growing field. So without further ado, let's get to the exhibit hall. So, Scott, thank you so much for joining us today for this special episode of the Sports Talks podcast, live from the AOSSM annual meeting in Washington, D.C. Welcome to our show.
Thank you. Thank you for having me here.
So you were one of the co-chairs of the Biologics Symposium I attended on Wednesday, and you moderated a session titled Point of Care Processing of Autologous Blood Products. Within that session, you spoke about the use of genetically modified human umbilical vein endothelial cells to augment rotator cuff repair. But before we get to that, we just wanted to talk a little bit about your interest in this topic, but really biologics in general. How did you initially get interested in this work, and a little bit about your inspiration and your mentors along the way?
So I've been interested in biologics for quite some time. In one of my roles at special surgery is I run a laboratory. I'm co-director of our orthopedic soft tissue research program. So I've worked in the area of understanding the cellular and molecular mechanisms of soft tissue repair, and that's led us into studying techniques for biologic augmentation, in particular cell therapies over the years. So we studied in the laboratory side, and the goal, as a clinician scientist, is to translate that to patients. So that's kind of been the initiation of our pathway. I mean, my mentors have been Russ Warren, Steve Arnowski, Joe Hannafin, and the others at HSS and research that I grew up with, and so we have continued that work, both laboratory work and then linked clinical trials.
Yeah. And can you speak a little bit about how you set up your lab and how it works? Do you involve residents, fellows, med students, people trying to get into med school?
Sure, yeah. It can take 10 years to really develop a robust research program. And so I have full-time laboratory technicians that do our histology, our tissue processing for molecular biology analyses, for biomechanics testing. We have postdoctoral surgeons, a number from overseas that work with us. We have post-baccalaureate students, and then there are research fellows. We have residents that are involved. We have medical students that are involved. So there's a staff of about really 12 to 15 individuals in the laboratory. So it takes a lot of time and sort of nurturing to keep it all going.
Absolutely. And so you've obviously published a lot of research on biologics. We want to dive in a little bit to that today, and we will eventually talk about what you presented on at the Biologics Symposium.
Okay.
We want to talk first about overall genetically modified cell-based therapies. So you've released a lot of papers on the use of genetically modified bone marrow-derived MSCs. Can you tell us a bit about what the data shows on that?
So this whole area of cell therapy, an area that has tremendous potential, but certainly needs further development. And one of the biggest, probably the single biggest challenge in cell therapy is the heterogeneity in these cell formulations, whether it's bone marrow-derived cells or cells from adipose, or even some of these perinatal sources, amniotic fluid, umbilical cord blood, things like that. They're all really poorly characterized. So the rationale for using gene therapy techniques was to insert a specific gene that we know has relevance for a specific tissue. So, for example, we did some work using, some years ago with Larry Gulott in our lab, scleraxis. Scleraxis is an important transcription factor in tendon embryology, tendon healing and tendon repair. So we inserted the gene for scleraxis into bone marrow-derived cells and evaluated that in an animal model where it has a positive effect. So that's the concept. Similarly, you can insert the gene, say SOX9, a master cartilage gene, to try to improve cartilage tissue regeneration. So great potential, an area that certainly needs further development. To scale it up to clinical translation takes further work.
Sure. So chatting about your presentation, which was wonderful, so thank you for doing that on Wednesday. So as we said, genetically modified human umbilical vein endothelial cells, and you were doing that to augment rotator cuff repair. So tell us a little bit more about the use of the fully differentiated endothelial cells rather than pluripotent MSCs derived from the bone marrow, and how you made that choice.
Yeah, so we've taken a different approach in some of our recent work using, as you say, endothelial cells. So to kind of back up, the whole area of biologics, I would submit to you there's two, whether it's cells or PRP, whatever. Two goals. One is symptom modification. One is structure modification. So we can improve symptoms. PRP in cell formulations will produce anti-inflammatory mediators and immune modulating proteins that can improve symptoms. But the harder, the bigger goal is, can we regenerate tissue? And so that gets to why we're looking at endothelial cells. So it starts with the concept of intrinsic progenitor cells, which exist in many tissues. So the cells that we put into patients, whether it's again bone marrow, adipose, whatever it is, those cells don't engraft. They simply produce a number of signaling molecules that affect the local environment. So anyway, we know there are intrinsic cells in many tissues, probably pericyte cells, lining the walls of blood vessels, that are intrinsic progenitor cells for that tissue. A lot of laboratory work suggests that those intrinsic progenitor cells are controlled by endothelial cells. So, and this is a long answer, but this is why we're studying endothelial cells. It's probably endothelial cells in each tissue that produce specific factors that control the intrinsic stem cells in that tissue. And it's tissue specific. So endothelial cells from liver produce factors that affect or stimulate liver stem cells.
Yes.
Endothelial cells from lungs stimulate lung stem cells. So the challenge is, how can we produce some population of endothelial cells that could be used for different applications. So this is working with the group Angiocrine Biosciences, is the company that supported this work. I have no other financial relationship with them. This is an investigator-initiated trial, so I wrote the protocol. They've supported the work. They manufacture the cells and produce these cells. So these are endothelial cells, as you say, human umbilical vein-derived cells that are, to make an activated cell population, they are transfected with this specific gene, this E4ORF gene. Like, what's that? So it's just a gene. It's derived from adenovirus, it turns out. But that, when you transfect endothelial cells with this gene, it confers sort of an anti-inflammatory and sort of pro-regenerative activities to endothelial cells. And it kind of increases their metabolic activity a bit, so they're stable in culture. So we have these cells now, these endothelial cells. They're transfected with this gene that makes them phenotypically stable in culture, so you can expand these cells at clinical grade scale, so you can eventually have master vascular cell banks. And these activated cells, when implanted, the goal is, or the rationale, they would stimulate the intrinsic progenitor cells that exist in tendon.
So then this genetic modification is different than what you did with the bone marrow-derived MSCs. Instead of doing like a matrix metallic protease gene or the scleraxis gene, you're just transfecting them with this to stabilize them so they can do their own natural duty.
Exactly. You hit the nail on the head. We try to make a slightly, metabolically active but stable population of endothelial cells. And then you ask an important point, kind of distinguishing this from bone marrow MSCs. Probably the biggest difference is these endothelial cells are a purified, well-characterized population of cells. These are manufactured, they're highly, highly purified. In contrast, bone marrow-derived cells, it's a gamish. It is a very, very heterogeneous mixture of cells. We don't really know we're putting in patients, frankly, when we use those.
How did you decide on umbilical vein endothelial cells? Because you mentioned like liver endothelial cells do this, lung. How was an umbilical vein chosen?
So this is done with scientists at Ansari Stem Cell Institute at Weill, Cornell in New York City, which is kind of right next door to HSS. So that's where a lot of the basic lab work has been done there, and then we did the animal work. They have decided on using human umbilical vein cells because they're available. These are an easy source of endothelial cells, kind of a generic endothelial cell, if you will, and then once transfected with this gene, you can kind of activate these cells, and so they will have these activities when they're put into a specific tissue. So it's a great question because it's probably context specific. That is, you put these cells in liver, they probably produce different factors. Put them in tendon, they produce other factors. So it needs a lot more work to understand the basic mechanisms. In fact, one of the things the FDA always wants is mechanism.
Yes.
That's
Sure.
lots more work.
So back to the study itself, what were some of the main findings with regards to the full-thickness rotator cuff tears?
Sure, thank you, Catherine. So we just finished a phase 1 study. It's an FDA. This is done under an IND, investigational new drug. This is biologic agent, so we have an IND. So this was phase 1, safety and feasibility, and the goal was to see, in particular, safety. Bottom line is these cells they do seem to be safe. We had no significant adverse events. We used imaging, MRI, and ultrasound to carefully evaluate the tissue. So we saw no evidence of any excessive inflammatory response. And then even more importantly, for any studies using gene-modified cells, there's certain things have to be done. So we demonstrated cell viability. There's actually 89% was the average cell viability, which is high. We had to make sure they're all negative for endotoxin at the time of surgery. And then following our patients, at 6 months and 12 months, we drew blood and using PCR demonstrated that the transduced cells were no longer there. So they're transient in their residence, which is good. So their cells aren't there at long term. Number 2, on the blood test, we looked at replication competent retrovirus to make sure that the retrovirus used to transfect the cells was not present, and it wasn't. And then 3rd is measurement of panel reactive antibodies, a measure of kind of sensitization to the cells. So of our 20 patients, 6 were sensitized to HLA, which is probably of no real relevance unless that patient needs eventual solid organ transplantation, kind of like a blood transfusion. So it's really, we've demonstrated the cells can be safe. Next step is to really look at efficacy, and that would, of course, take a randomized trial.
So we talked about cells and testing the cells. How are you delivering those cells to the area of the rotator cuff, and then how are you keeping them there once you get them there?
Yeah, that's a good question. Actually, that's always one of the biggest challenges: how do you get them there, and more importantly, how do you keep them there? And so we inject the cells we take blood from the patient, we isolate plasma. Plasma has fibrinogen. So we've got fibrinogen. We mix it with thrombin and calcium chloride to make sort of a clot. So we inject it with thrombin and calcium chloride that makes a clot at the site. So that hopefully keeps it in where we want it to be. So we're injecting it at the tendon attachment site, the repair site, and then also in the muscle. So I'll kind of finish the repair. Just do standard repair, nothing different, and then put a needle into the muscle, one of the tendon repair site, close the portals, everything, take the scope out, drain the fluid, and inject the cells, and hope they stay there.
For the best.
Right.
No, you brought up our next question was really about the muscle. So you did inject the muscle. Tell us about why, and what's the goal of that? Why was that so important?
Catherine, the reason we inject muscle is, as you know, one of the challenges in rotator cuff pathology is changing the muscle. Atrophy, the fatty infiltration. So not only is the goal to get the tendon to heal to bone, but could we even reverse some of the changes in the muscle there? And so we included patients that had frankly minimal fatty atrophy. So we don't expect to see much big change, but potentially these cells could either halt or even ideally reverse the atrophy you see in muscle, which is something that's an unsolved problem. Even if we have a quote unquote good repair and quote unquote healed tendon, often the muscle doesn't get better. So that's the rationale to start to see, could we affect muscle physiology?
Yeah, was there a, did you look at a certain level of atrophy that those folks were not able to be included, or was there
Yes.
there?
So they had to be Guttelier 2 or less, so not the advanced changes.
Sure. In some of the other literature you published on the genetically modified bone marrow-derived MSCs, it was also injected into the supraspinatus muscle?
It was.
Any changes in the muscle composition or appearance with those?
Nothing that we quantified, not a whole lot. And we used a fibrin glue material. Back to your very good question, actually, about carrier vehicles. We used fibrin glue. which kind of like makes a little bead, and it kind of and the cells like fibrin. They're kind of happy in fibrin. They're stay viable, and it kind of localizes the cells to the site. So that would be another potential sort of carrier vehicle. Carrier vehicles are an important part of this.
Yes, exactly.
Yeah, important part.
Exactly. So do you see any application in the non-operative patient outside of the actual repair?
Absolutely. Great question, Catherine, about non-operative treatment. Could you use this in say, partial cuff tears? Those are a challenge to me. We see this all the time, right? These partial tears, and there's partial tears, and there's partial tears. I mean, some of these are completely asymptomatic, but some aren't, and some progress. So could you simply inject these cells in the subacromial space?
Right.
Absolutely. I wonder about using them as well for meniscus. Could you, same underlying concept, could you try to stimulate the intrinsic progenitor cells that are in many of these tissues? They're quiescent in these tissues. How do you stimulate them,
Yeah. Go ahead.
I know. I was actually going to transition us into rehab after you. So with biologics, I know this is kind of in the initial phase of studying, so you're not doing this in patients yet. But if you're doing biologic injection or augmentation, how do you adjust their rehabilitation? Do you do a period of activity shutdown to let it take effect? When do you start that?
It's a great question, Ashley. I think we, frankly, don't have good data to really guide us in what we should do it for rehab. Quite simply, I've not really changed what I've done. Whether, clinically now, in my own patients, I will occasionally use bone marrow-derived cells, and say, massive tears or revision surgery, poor tissue quality, and I don't change what I do rehab. But frankly, we need more information there. And the real question, rehab is mechanical load. So the question is, how does mechanical loading affect cells and cell biology or PRP? Totally a black box. I think something we really need to start to study. Frankly, maybe in collaboration with our rehabilitation colleagues, really look at this in a rigorous fashion, because right now it's really arbitrary. Even like after PRP, people say, rest for 2 days, rest for 3 days, rest for 7 days.
Exactly.
I mean, it is like so arbitrary. The reality is, if you look for any data to support these recommendations,
There's none.
it doesn't exist.
There's Google.
Exactly. But at the end of the day, as a clinician, you've got this patient sitting in front of you. You need to tell them something. And we acknowledge that we need rigorous data.
Yeah, so Scott, my background before I went to medical school, I was a physical therapist for 7 years. And so that was a lot of my frustration, where I felt like it was very hard to get real. Our RCTs were very, very rare. Yeah. And so we spend a lot of time talking about rehab on our podcast, because it's a little bit of my sort of pet project. But when folks come in my room and I'm doing any sort of biologic, and in the non-operative, I'm not very conservative as far as I'm letting them get back. I'm not really restricting their activity, but I do sometimes have patients come in and say, I found something on the internet that says I really need to shut down from anything strenuous for 6 weeks. And I don't have a reason to sort of agree with that. I don't know if you've kind of come across anything, or you have anything more at the cellular level that would make me think differently. Yeah, no, I think I have the same issue, Catherine, patients all the time, to educate our patients, because they come with all sorts of protocols they hear and see, and no, Dr. So-and-so told me I need to do this. And it's like, I know that I don't know. I'm pretty sure he doesn't know. I mean, so I think part of our job is to educate our patients, say, listen, there's a lot we don't know. Now, but more specifically, mechanical load has a profound effect on physiology, obviously, and certainly connective tissue. So no doubt the mechanical loading, which again is the rehab, whether it's volume, frequency, intensity of exercise, what exercise you're doing, how, when, that will no doubt affect the biology. But boy, we just don't really, and I tend to be, I don't make much adjustments, because I don't know what to really truly recommend.
Well, we've talked a lot about rotator cuff, non-operative and operative use of these cell-based therapies. Do you see any other conditions, orthopedic pathology, that may benefit from biologics? I know we talk about augmenting quad tendon injuries and Achilles tendon. Where do you see this going? Yeah, for sure. I think, again, back to the underlying rationale, the ability to try to stimulate intrinsic progenitor cells cuts across many tissues. So, for example, could you use these? I wonder about meniscus tissue. Muscle, I think, has great potential. We don't have good solutions for muscle injury. I take care of a football team in New York. We see lots and lots of muscle injuries where we don't have great solutions for the fibrosis that occurs. So that's, I think, a rich area. Yeah. Absolutely. And obviously, cartilage repair is a huge black box and a huge unmet clinical need. So I think we need to understand how we can stimulate the intrinsic cells in those other tissues, meniscus, cartilage, muscle, bone, for that matter. So, yes.
Just because you brought it up, my father would be very sad if I didn't say "Go Giants." So
great. I like your father already.
Ashley will, she'll.
I'm an Eagles fan.
Eagles, a small team somewhere south of us.
Yeah,
I've heard of them.
Exactly. They're finally good for the first time in.
They're very good.
years.
Unfortunately, they're very good.
I know.
But But I think the last thing we just really wanted to end on is what advice are you giving to early career surgeons in the sense of biologics? It is so vast now, it's huge. So I think, if you don't get a lot of exposure to it in your residency or your fellowship, it just sort of feels like this huge black box. Like where should people start?
Yeah, great question. I think, biologics, I would submit to you honestly, what arthroplasty was to orthopedics in the 70s and 80s, biologics could be in the next decade. So it's here. It's not going anywhere, but it needs much further development. I think I tell patients and my colleagues and our trainees, tremendous potential, but a lot of us probably not yet ready for prime time. So what does that mean? Study it rigorously. I mean, clearly patients are going to come to you. They want PRP and cells and things, and they're probably reasonable enough to do. They're safe, but, and it's a big but, I would say put your patients into a clinical registry, collect data. Ideally, if you can take a small aliquot, a half cc, whatever you're putting the patient, store it in the laboratory. Eventually, if we can identify what are the markers of purity or potency or biologic activity, some things we can measure.
Sure. Because,
again, back to the point I made earlier, probably the single biggest challenge in this area is the heterogeneity. If you give a drug, you know what concentration, obviously. Here we have no clue we're putting in the patients. So this area, patients will want these treatments, and I think that's reasonable to do it, but do it in a rigorous fashion. Collect clinical data. If you can collect a specimen that we can eventually, ideally, our goal in our center at HSS is to measure the composition and biologic activity of all these different formulations and then correlate that with the patient's clinical or imaging outcomes so we can eventually figure out what is the best formulation for muscle, for tendon, for ligament, for bone, because clearly one size doesn't fit all. So for your trainees, I think embrace this area, learn the science, be open-minded, but study your patients carefully.
great advice.
That's wonderful advice. Well, thank you so much for taking the time to join us today. This was a fantastic discussion. We know you're extremely busy, and so we really appreciate you taking
Thanks
the
for having me.
time.
Yeah,
Thank you.
I learned a lot. Thank you so much.
All right,
Thank you.
Awesome.
Thank you for listening to this episode of the Sports Talks. We hope you enjoyed the discussion as much as we did.
Make sure to subscribe on Apple, Spotify, or wherever you get your podcasts to stay up to date on all things sports medicine. Exciting announcement, we are also now on YouTube. You can find links to all of our social channels and our contact information on our website, www.thesportstalkspod.com. We love to hear from you.